laceration 7 say sir, knee joint it is communicating sir, but it is superficial, non-infective. We have done close reduction internal fixation and interlocking nail for right femur with wound debridement sir, and we had closed the me. Yes sir, deep fascia is intact sir, only superficial. Sir, ILN. Sir, actually 15 years old. G, the entry ILN. Sir, actually in pediatric age, the entry point is at the tip of the. Yes, sir. 15 years. Sir. Yes, sir. After more lateral.
15 years bone vascularity will be very good. Anyhow, they do in it.
Another thing is still the growth spot is there. You not remove as a left. Otherwise there is limb line disturbance.
Sir, this is the case for discussion last week we had done, sir. 28 years old male with 1 year 6 months old supracondylar fracture of left femur with broken DFN in situ, and distal third both bones have fracture of left leg with implant in situ ILN. Sir, no, no, tibia is united.
Nail broken.
Yes, sir, DFN nail is broken, sir. Yeah. DFN is broken, sir.
Nail is broken.
Yes, sir. The distal part of DFN had removed from
Is there a
T can, right? Sir, no, sir. Sir, the medial cortex is still. Sir, somewhat. Yes, sir, but we tried, sir. Mobility had checked, but not appreciable. But there is no mobility intra also, sir. So.
distal fragment is so small. They are only condyles. So it's very difficult to elicit the abnormal. If you try to elicit the movement and the actually giving a false appearance as if there is abnormal. Here the radiologically fracture has not been made.
Yes, sir.
That is why the nail was broken. The gland.
Sir, we have removed. Sir.
So otherwise, mainly the rotational deformity process cannot be corrected. Otherwise, the nail should have to go up to the level of pressure. Then only it is more biological construct. Biological biomechanical.
Sir, actually worried about broken nail and healing status. Fracture had not united. Yes, sir. Yeah. Sir, there is callus formation. Removal of DFN and plate augmentation had done, sir, and not done any bone graft, sir. Yes, sir. Yes, sir. Yes.
What do you mean by plate augmentation?
Sir, actually bridging
The word
plate.
plate augmentation. What do you mean by that?
Sir, support fracture. Plate. Plate augmentation.
What do you mean by plate augmentation in your description? Augmentation is something which is added to something else. That is augmentation. Adding something. Primarily doing plating is not plate augmentation.
Okay. Sorry.
Use the word
Actually,
very carefully.
okay.
Suppose if you want to use the plate
Additional.
augmentation philosophy, what do you want to do?
Again, we need to insert DFN, and again after removal of this broken nail, we need to redo DFN and redo nail and small recon.
If you have a doubt regarding the clarity, it is small graph.
So
That will be a less traumatic procedure than the plating. The surgical trauma will be very, very
Yes.
minimal. Because removing and redoing the nail is very, very simple.
Sir. Yes, sir. The distal part had removed from parapatellar approach, sir. And the proximal part we had pushed the nail from piriformis to down, sir. No, sir. Yes, sir. We had struggled.
You have to open the fracture size if you want to remove the
Yes, sir.
cardinal. You have to open.
We had opened for.
And open the medullary canal.
show me where is the fracture site? Point at
Sir, we have taken that broken in extraction. So inserted from history to the when you are tightening that broken in, that itself has broken in. That plates are broken in. So we don't have any other chance to put it from the so then we have opened it from
Okay,
But if you have a doubt regarding the quality of the unit, how are you going to assess? Now,
one
it is
after.
linear. But radiologically it is not consolidated. You can end up 1.5 years. But to an young man, how are you going to assess regarding the quality of the unit?
One. Actually, I was not there.
ఎవరుంటే వాళ్ళు ప్రజెంట్
Case.
our energy pass.
we have removed it.
Fracture site and the broken nail are both at same level. Huh? Fracture site and broken nail both at same level.
Yes, sir.
Can you zoom like this?
Margins are looking stable.
Zoom like this.
This
Zoom like this.
doesn't look.
That is why in doubtful cases,
the deeper and the proximal LCP interlocking bolt is interlocking or
Interlocking.
interlock. See, it's purchasing both the cortex.
Yes.
So some people say it's unicortical. Some why? See? So bicortical is not unicortical. So which is better? Unicortical is better, bicortical is better. School of study.
Bicortical is
Why bicortical, why unicortical? Difference.
the plate of
Huh?
rigid fixation will be there. At plate.
Now in plating, always
Stress effect on fracture.
communicated, sir. Extremely. So we have done open reduction internal fixation with long PFN with plate augmentation for this also, sir. Philos plate only, sir. Philos, sir.
What is the advantage of Philos over other plates?
Fixed angle construct, sir. Fixed angle construct. Fixed angle construct.
Fixed angle construct. Philos fixed angular ఉంటుందా? Where is the plate kept?
Here it is kept in posterior position, slightly lateral position, sir. Yes, sir.
This fracture reduction is very, very important. This fracture reduction is highly demandable.
Yes, sir.
Reduction, retention and fixation. Going putting and
Yes.
use the rubber. So reduction is very, very important. One person should know how to reduce the fracture. You have to lift it because the distal fragment goes sags down.
Yes, sir.
And there is a condition, there is no there is no surgical contact with all the fragments.
Yes.
So lift it, hold it, or you see I'm sharp left double count it.
Yes.
So the person who is reducing, who is exposing for more of CM shots.
Yes.
That is one person. So the people say, no, I don't hold. So one person should have to wait for the reduction.
Both are unstable only, sir. Unstable. Sir. Yes. Yes.
So weight bearing should be delayed.
Delayed, sir. Delayed.
35 years old female with closed middle third both bone shaft fracture right leg, sir. We have done close reduction internal fixation with interlocking lane, sir.
How many days old fracture?
Fresh, sir.
No compartments.
No, sir.
Please go ahead. Next.
56-year-old male with intertrochanteric fracture of left femur, sir. We have done close reduction internal fixation with PFN for left femur, sir.
What type of reduction is this? Positive, negative?
This looks like positive only, sir.
Next.
But how many of them this
This week 3 cases happened, sir. Only this week 3 cases. Okay, sir. Okay.
Good morning, sir. This case done in Unit 2. 83-year-old female with intertrochanteric fracture of right femur with subtrochanteric extension. So there is old pubic rama injury, sir. And then open reduction, internal fixation with long PFN with cerclage wire and bone grafting. Sir? 75. Mistakes. 75.
Year-old female with intertrochanteric fracture of right femur with subtrochanteric extension. We have done open reduction with PFN for right femur and augmentation with a Philos plate. స్టెబిలిటీ ఇంప్రూవ్ చేస్తుంది సార్,
హౌ
ఆగ్మెంట్ చేసి.
into symbology. So the lateral column, you have to stabilize the lateral column. So what about reduction is this positive, negative, neutral? Go back.
75-year-old
Go
female.
back on the side. So what about reduction?
Neutral.
Huh?
Neutral.
Very good, excellent.
So-
You are larger than points. Next.
75-year-old female with intracapsular fracture neck of left femur. Bipolar cemented hemi-arthroplasty for left hip, sir.
మన friend is ఇదేనా?
ఇది
This is
ట్రాన్స్సర్వైకల్ subcapital.
See the vertical offset and horizontal offset. Both are increased. The horizontal offset so much of lateralization.
Yes, sir.
Lateralization. Vertical also see the level of the escape suppressor on the right and the left.
slide.
Right. So it has to be there.
It will be this.
When you are doing cemented, problem of alpha strength doesn't matter because it rests on the cement. Otherwise they will have erosion.
Subsidence.
Subsidence.
Erosion, protrusion.
Basic illusion.
Nucleus medius becomes unduly big. It loses its power.
Yes. Forty-year-old male with 1 year 6 months old post-op follow-up case of supracondylar fracture, femur fracture with implant in situ. It was an infected case. We have done implant removal and wound debridement. Sir,
What is this wire?
Intramedullary wire, what is it?
I don't know, sir. I was not there for this.
This operated here,
There is other view, lateral.
No, no, sir.
elsewhere.
There is a lateral view.
ఎండర్స్ లాగా లేదు సార్ అది. ఇట్స్ నాట్ లైక్ ఎండర్స్ నెల్ సార్.
There is the lateral view.
Sir, pointer ఉంది. Use the pointer. Later pointer ఉంది చూడండి. Use करो pointer use करो. वो नहीं दी pointer है पास. Use करो pointer use करो बड़े साहब.
సార్ ఎండర్స్ లాగానైతే లేదు సార్.
Wide గా ఉంది.
No idea, sir. It was not done in our hospital. Not here, sir.
But when you have removed it, what was the type of?
We were not there, sir. Vishal was there, sir. He's already there.
Okay. What is the skin necrosis is there? Was the skin necrosed?
It was necrosis.
Why was it necrosed? Fracture is not an infected fracture. Why did the skin get necrosed? Is it necrosed or only discoloration?
It is necrosis.
What was the duration of the discoloration?
1 year 6 months post-op. Maybe
Since 8 months.
Reaction.
supracondylar femur.
Who was there while it was being done?
Vishal was.
And it is an infected implant.
To assist present there.
Yes.
లేకపోతే ఏం ఇన్ఫర్మేషన్ తెలియదు. In presence of metal reaction there will be blackish discoloration all around the plate. No metal. Then why did the skin get displaced?
Sir, it is 1 year 6 months old. Do you consider it as a superficial infection or a deep infection or infected implant?
Infected implant.
Infected implant.
Radiologically there are no signs of infected.
Yes.
No lucency.
Go back. It's all important. Management of infected implant is a 10 marks question. After those, Nipura, university exam.
42-year-old male with 1 year 3 month old post-op follow-up case of closed distal femur fracture of left thigh with implant in situ, and 3 years old post-op follow-up case of closed tibial plateau fracture of left leg with implant. Yeah, we have done implant removal here only, sir. Surgery it is not done here, sir. Only distal femur we did, sir. Yes, sir.
Okay, done. ROM.
ROM 110 degrees.
ఏంటి 100 ఫ్లెక్షన్ ఎక్స్టెన్షన్
ఫ్లెక్షన్ సార్ ఎక్స్టెన్షన్లో అంటేనే ఎట్లా పోతుంది సార్
తెలియదు మీడియం
సార్ ఎక్స్టెన్షన్ అంటేనే ఎట్లా పోతుంది సార్
90 100
79-year female with 1 month old intertrochanteric fracture of right femur, sir. We have done close reduction. Bed sores were there, sir. Sir, bed sores ఉన్నాయి. ఉన్నాయి, sir.
Same side. That's
Side
all.
of
Yes, sir, same side. That's why we couldn't do. Yes, sir. We couldn't do a PFN, so we went for endosnail and rational, sir. Tense, sorry.
That's a very good decision.
So they came with
Sir?
the infect.
Conservative.
Presence of resource. How are you going to treat the bed sore? Orthopedic means it's not only treating the bed. How are you going to treat the bed sore? Not ideal.
ఏం చేస్తున్నాం?
What is that?
Back.
What is that?
In surgery they use
Surgery.
vacuum. It is a machine, sir. I don't know what is it, but
And
I saw it in internships.
what is that? Expand that.
No idea.
Anybody? From behind.
Firdaus is telling. Bola Firdaus. Bola
Go ahead.
Altiraj Paran
He
bolo.
doesn't want to say. Anybody from behind? Below.
vacuum assistant.
సార్ జనరల్ సర్జరీలో చూసిన సార్
General surgery వాళ్ళు చేస్తారు. Orange. Vacuum assisted closure.
క్లోజర్
What is the other name for that? Anybody? Negative pressure wound therapy. NPW.
Closure.
Okay. What is the benefit of that? You read it.
Yes, sir.
The important question in the examination. Huh?
Yes.
So they are presented with the bed sores.
Yes.
It sucks out all the inflammatory edema and all the discharge whatever is there. It improves the oxygenation of oil and it gets granulated very soon. Within a week time, all the infected granulation also becomes a very good vascular granulation and healthy granulation is being created. So wherein you can treat the and the also gets significantly reduced. In size also is reduced, and the flap surface is very good. Suppose if it is in the sacrum, it is a subcutaneous bone. Sacrum.
Yes.
You need it in that or right?
Right.
The wound is clean. Otherwise, if it is on the bone, you have to do rotational flap, local flap.
Rotation flaps.
And you have to talk about the classification of the vessels also. Next.
We have done close reduction with enders nail and tens nail, sir.
Undersnell tension, both.
Enders nail ఒకటే ఉండే సార్.
So which is the entry point? Lateral entry point?
Medial, medial, sir.
Medial entry point.
Medial.
73-year-old male with intertrochanteric fracture of left femur. It is AAO-OTA type A2-3B, sir, with a coronal split of greater trochanter, sir. The fracture. Intertrochanteric. It was like this, sir. So we have done open reduction, internal fixation with PFN and augmentation with 2 pillows plate, one anterolateral and posterior. Yes. So just a picture depiction of this coronal split of this greater trochanter. So we have fixed this part and this part both. Yes.
Yes, good. Very drying. Yes.
62 year.
Coronal split is depicted. Coronal split. Okay.
62-year-old male with closed comminuted fracture of right patella. There was intra-articular incongruity, sir. We have done open reduction and fixation with tension band wiring for patella. This step was reduced, sir, and congruity is maintained.
Use the pointer, madam. You got a pointer. No, I keep pointer. Use for the pointer. Restored.
Yes.
Excellent. And do you want to mobilize? Okay, slab.
We can, no, sir. Just long knee brace we kept for 2 days. That's it, sir. We started mobilization. Sir? Age 62 years, sir. Okay. 38-year-old male with 5-month-old ununited left femur shaft fracture, sir. We have done open reduction and fixation with interlock. Sir?
What is the problem that you are going to face on the table?
Bleeding, sir.
You are not
Profuse bleeding.
whether there is any
Shortening is there, sir.
displacements,
Yes.
and then uniting or
Not ununited, sir.
united.
Ununited, sir. Abnormal mobility was there, sir, and limb length shortening of 4 centimeters was there.
And there is overriding.
Yes,
There
sir.
is evidence of callus.
Callus, sir.
Can you reduce it on the table?
Yes, sir. We have cleared the
You are likely to encounter with
adhesions, sir. Callus is there, sir.
problem of reduction.
Reduction. Callus is.
Overriding. When you try to acutely reduce the fracture, copy, the femoral vessels and nerves get stretched. You are likely to cause blindness. Did you think of that?
Yes, sir.
Very, very important.
Yes.
Reduction is
Yes, sir. Good. Reduction was good, sir.
shorten the bone.
No, sir.
How easy was it to get reduction?
It was difficult, sir. We cleared the tissue around and then. No, sir. We have not taken callus out, just surrounding. We have cleared the surrounding area, sir. Around the fracture site, sir. Yes.
You have to strip the soft tissues right up to the
Sup-
region and far below the fracture site. Then only the soft tissue cases up.
Yes.
But even then, because of the 5 months of shortening of the soft tissue, the vessel
Range of movement is restricted to 70 degrees only, sir. Knee movement. Even before surgery, it was the same, sir.
so suppose if you cannot get reduction in spite of tripping, what are you going to do? How are you going to achieve reduction?
Yes, sir. Shorted the bone grafting.
Similar distractor. Have you seen that? Ask the system next time when you go to the OT. You can fix the distractor and then distract the fractures. But this case was 4 inches shortening,
Yes.
not 4 centimeters. But the problem is that vessel spasm, femoral vessel spasm, that should be thought of. How was the vascularity of the
Good, sir. It was good. After yes, sir. After removing the sclerotic border, punctate bleeding was seen, sir.
If you have a doubt, you put a pulse oximeter into the toe, and then when you have reduced the fracture and kept it reduced, see for the
Capillary.
saturation in the monitor. And then if it is getting reduced, you shorten the bone and then fix it. Rather than allowing it to go into the bone. That is the precaution that you should take in this case. You must anticipate this problem. Who was the surgeon?
Sir, Lakshmi.
ఈ ప్రాబ్లం ఏంటి చెప్పులు లక్ష్మీకాంత్ వాళ్ళని నేను వదిలేకట్లాగా యూ హ్యావ్ టు కమ్ టు దేర్ రెస్క్యూ ఎనీ ప్రాబ్లం ఇన్ రిడక్షన్
No, sir. Yes, sir. Yes, sir.
Without difficulty. Hey Guru, what is the difficulty in proximal distal?
Initially 90 degrees and then eventually 60 degrees. But after the pain, you see for the irregular back, hotness is there or not?
No,
It
sir.
is not what is
We have to release.
it gets stressed. The irregular back from there it gets stressed. The problem comes not stress, it gets excessive. Sometimes
We have-
John, make one record in the irregular back, then it gets stressed.
I have checked for knee movements after reductions.
Becomes taut. That has to be released. This is developed. Knee, this is called launch release.
You know what is the answer release?
Yes.
Any idea?
Above
Launch release.
iliotibial.
Southerns release, Jones release under Jones, YOUNS, Southerns release. Southerns.
3 months.
IT band అంటారు. Okay.
And bone grafting
So
was
there is
also done.
plenty of callus.
Yes, sir. That
Did you check for the saturation after nailing?
for leg we for leg we didn't see.
You didn't anticipate. You have to.
So this is the general discussion today, sir. Purchase of both proximal and distal fragments by Kalkar screw is critical when using a locking plate in the treatment of proximal humerus fractures, sir. This is published in Bone and Joint Journal 2025, sir, from Korean University, Annam Hospital, Seoul, in South of Korea, sir. The study period was January 2012 to December 2022, sir. The aim is the inferior position of the Kalkar screw is important in the purchase of medial screw when treating proximal humerus fracture with a locking plate. However, the impact of the overall trajectory of the calcar screw has not been investigated. The aim of this study was to investigate whether the purchase of calcar screw to purchase both proximal and distal fragments would contribute to an increased risk of fixation in these patients. Sir. Results, sir. This is a retrospective study, sir. Sir. With purchasing and purchasing and non-purchasing groups. Retrospective cohort study, sir. Study center is Korean University affiliated to tertiary hospitals. Duration is January 2012 to December 2020. So sample size was 163 patients, sir. This is divided into non-purchase group 61 patients. Purchase group is one or two patients. Sir. Inferior medial. Yes, sir. Yes, sir. Yes, sir. The screw was not intersected with the fracture line is purchase group, sir. Yes, sir.
So purchase group means it should be both distal and
proximal through the fracture line. Yes, sir.
Non-purchase means purchase only one fragment.
No, sir. Two fragment, but not crossing a fracture line, sir.
The purchase means both the fragments.
Both the fragments. Yes, sir.
Non-purchase law, you are not engaged in the both the fragments.
Yes, sir.
There is no purchase between the both the fragments.
Fragments. The picture, yes, sir. Purchase group, the calcar screw trajectory intersect the fracture line, indicates successful purchase of both proximal and distal fragments.
Purchase of both proximal and distal fragments.
In non-purchasing group, calcar screw did not intersect the lower margin of fracture line, indicates fail to purchase of distal fragments. This is the, yes, sir. In purchase group, is intersect the fracture line, sir. In non-purchasing group, it not intersect the fracture line, sir. Inclusion criteria: proximal fractures treated with locking plate, that is Pillow system, sir. Exclusion criteria: follow below 1 year, isolated tuberous fractures, bone grafting and dual plating, concomitant humeral shaft fractures. Primary outcome failure of fixation is in purchase group is 31.2%, sir. Out of 61 patients, 19%. In purchasing group, 3.9%, sir. 4 patients out of one or two patients. So mode of failure as varus collapse is most common, non-union and screw loosening, malunion and screw breakage. This is they are not mentioned, sir. Yes. In post-op complications and failure fixation is 3.9% in purchase group, sir. 31.2% is non-purchase group, sir. Non-union is 1% in purchase group, 18% is non-purchase group. And varus collapse and loosening is rare in purchase group, common in non-purchase group. And AVN and osteoarthritis changes are rare in purchase group and also non-purchase group, sir. This picture shows the in purchasing group the forces acting on both medial and lateral sides, sir. In non-purchasing group, forces acting on medial sides, sir. It leads to varus collapse. Yes, sir. Yes, sir. Important. Yes, sir. To prevent varus collapse. Yes, sir. circumflex arms. Yes, sir. Sir. No, sir. The angle so in reverse oblique fracture, the angle between fracture line perpendicular line to the shaft of the humerus, sir. This angle is more than 20 degrees in reverse oblique fracture, sir.
What does it matter? Will it give purchase or no purchase?
And purchase is difficult in reverse oblique, sir. Yes, sir. More than 10. Many, sir. Suturing.
How to make out collapse?
Yes, sir. With the neck shaft angle is more than 120 degrees, less than 120 degrees varus collapse. Yes, sir, make out. Yes, sir. And follow up, sir. Yes, sir. Malinian, non-linear. Yes.
So the placement between the tip of the acromion to the greater tubercle should be more than 6 mm.
6 mm.
Then only we should consider or impingement or collapse. Then we will collapse.
Yes.
Conclude.
Calcar screw purchase across the both fragment is critical for biomechanical stable in proximal humeral fracture fixation. So, fixation failure was significantly higher in the non-purchase group despite similar fracture complexity, reduction quality, alignment, calcar height and screw numbers. This indicates the failure is due to inadequate medial load transfer, not poor reduction of fracture severities. In reverse oblique fractures, increased risk of non-purchase, but fracture factor is predisposing factor, not an independent cause of failure. Traditional parameters like calcar screw height, screw density, immediate alignment did not predict failure, challenging existing fixation principles. True calcar screw engagement should be prioritized to restore medial support and prevent late mechanical failure, especially in reverse oblique fractures. Criticism. This is a retrospective study, sir. Calcar screw purchase is assessed only on plain radiographs without CT confirmation, and no functional outcome measures were included, sir. Conclusions are limited to radiological and mechanical failure without clinical correlations.
Even then it is accepted.
Yes, sir.
What I have seen is about more than half getting collapse. In the experience, how many experience? It is conditional. You may not achieve
Most of the times conservative treatment will be better results than
Failures.
in selected cases.
Constant modulus for CMS for
Failures, sir.
పెట్టాలి అయితేనే నీకు తెలుస్తుంది.
ఓకే
So here, now ఇక్కడ function, here you are
చాలా ఎక్కువైపోయింది ఈరోజు.
2-part, 3-part fracture is different from 4-part fracture. All are not same. ఇప్పుడు చెప్పాలి. Constant and Murley functional outcome
Murley.
is very very important. You are not shown any functional
dash
outcomes.
dash score.
Yes.
Murli, Gopi, we log out here.
అన్న function. అది పెట్టాలి. నువ్వు చెప్పావు కదా, నువ్వు చెప్పడానికి క్రిటిసిజంలో చూపించావు కదా.
చూపించాను. నాట్ పేపర్ సార్,
అది నీకు పంపించాను చూడు. ఏం కాదు,
మీకు పేపర్ ఇచ్చిన జిరాక్స్ ఇచ్చాను సార్. దీపక్ గారు
no functional outcome criteria has been taken under the functional outcome criteria
ఇచ్చినా కదా నేను శ్రీకాంత్ సార్కి ఇచ్చిన, మళ్ళీ కావాలంటే ఇస్తా. సార్ మీకు కావాలా సార్?
ఇచ్చారు కదా నిన్న,
మళ్ళీ
నిన్నే ఇచ్చేసారు. నీకు ఇప్పుడు పంపిస్తాను తర్వాత రేపు చెప్తాను.